Bovenkamp, and are you going to be presenting by yourself? I see that Harvey Mathews is there. He's just going to hang out in the background?
Something like that.
Okay, all right. Well, sir, if you would please put your name on the record and please begin your presentation.
Yes, thank you, Chair Manning. Good morning, members of the committee. My name is Harvey Mathews. I serve as Legislative Director for the Oregon Department of Corrections, and I will be introducing Assistant Director Kevin Bovenkamp, who is live on site in Eastern Oregon, where he is doing visitations of our facilities over there. As you may know, we have 12 facilities across the state. They operate on a 24/7 basis. We employ over 4,700 Oregonians to serve those institutions and our 12,000 plus adults in custody. Health services is incredibly important for the Oregon Department of Corrections, and we are very pleased to have hired Mr. Bovenkamp this last year. This is his 98th day on the job, and he has been doing great work. He comes to us with a great amount of experience. He previously served as Assistant Secretary of Behavioral Health in Washington for their Department of Social and Health Services, and then also as Assistant Secretary of Health Services for the Washington State Department of Corrections. So his experiences allowed him to come in to our organization and hit the ground running on helping identify issues and solve problems. So he will be joining us here and going through this slide deck, and I will be here to help in case anything happens.
Right. Sir, would you please put your name on the record and begin your presentation?
Yes, good morning. Good morning, Chair, members of the committee. For the record, Kevin Bovenkamp, Assistant Director for Department of Corrections, Health Services. And I apologize, I'm not able to be there in person. As Harvey said, I'm in Eastern Oregon touring facilities. I'm actually at the Powder River Correctional Facility this morning. And we'll be going out after this presentation to take a tour and meet the staff and talk with some AICs and others. So I've been getting around the state and getting to facilities as I can. And so I'll get 4 facility tours done this week. So thank you for having us this morning. And I'm going to share just a little bit of information around geriatric care and what that means in the Oregon Department of Corrections. If we could go to the next slide, please. Oregon, not unlike other states and jurisdictions in the country, does have an aging population in correctional facilities. And I did attach, on the very last slide, I did attach a few articles that may be of interest to committee and others. Nationally, corrections defines aging really around age 55 and over is sort of how we're counting it. You'll see that in some of the literature. The correctional population does tend to age and have a little more illness than the general population out in the community. So there's some extra things we have to do here in facilities. I'll run through some of the concerns we have this morning and then talk a little bit just about future plans. So if we could go to the next slide, please. And keep on going. Sorry about that. So here is, Harvey mentioned, we do have 12 facilities. I'm over at Powder River in Baker City this morning. And these facilities are a mix of different security levels, different ages, different constructions. And that's one of the things that's really important to take away with the geriatric management. Is really our facilities, we're not designed to manage this kind of population and the healthcare needs and just daily living needs that they have. So as we're turning around facilities, we're looking at places where we may be able to house people more safely and effectively than they may have currently been. And it's a challenge for us, and we'll talk a little bit more about that as we get going here. So next slide, please. In health services, as Harvey said, I've been here just a little over 3 months, and the things we're really working on, and these were outlined in the Falcon report, which I'm assuming many people are familiar with, really here in the early phases, we're working on 4 really important things at this time and into the coming months. One of those is clearing the backlog of appointments. and specialty care. So not all of our AICs can be cared for on premises. So there's oftentimes we have to send them out to community for providers, go see specialists, and we've been clearing that backlog. And just happy to report just at Snake River Correctional Facility yesterday, I think that backlog's been cut down pretty significantly. And talking with the schedulers, they're now scheduling appointments for orders that came in from physicians just within the last few weeks. So they've actually done quite a bit to catch up. We are putting quite a strain on our transportation system, and some of the specialty offices, just like many of us that live in the community, it's not always easy to access specialists out there for the care that we need. And so there's oftentimes delays in getting in those first appointments. And that is especially true of those in our correctional system as well. Secondly, we're implementing the electronic health record system. This has been a project that's been planned for years. Happy to report that we did implement just a couple weeks ago at our first site, which was the Oregon State Penitentiary. It went exceedingly well. It doesn't mean it went without a few little nuances and bugs that we had to fix and resolve as we got going. But so far, the report from staff is the system's working very well, and it's much appreciated and much better than the volumes of paper records and binders that staff have been working with for years. So we do look to the next phase of rollouts will actually be in middle of January, and we're going to do 3 more facilities in January. So that team was actually at Snake River yesterday, which will be one of the next facilities, and making plans for that January implementation. So things are going really well there, and happy for the support we're getting on that. Thirdly, we're working on breathing some new life and structure into the quality improvement program, continuous quality improvement program. This is something that helps us track the quality. It's been, I think, lacking and unstructured, and so we're putting some structure behind it now. We're getting ready to hire, hopefully recruit for a new chief of that program. That's a position that's being developed, and then we have a draft policy ready to be reviewed and hopefully published here soon. And we're starting some internal activities already, like internal peer audits and surveys, looking at more data. As we get to electronic health records, we will have more data available, which will help that program immensely. And then lastly, we're working on doing some updates to the health services administrative structure. I've been talking with the health services leaders and the Falcon team who wrote the report, and probably anticipate making some structural changes, publishing those in January of 2026. So if we go to the next slide, please. I was talking a little bit about our aging population. This is some data from Oregon DOC, and you'll see just 10 years ago, those over 55 and incarcerated were 12% of the population. Recently, it's been 18%, and we do expect that to continue to grow. And you'll see in some of the literature, there's predictions that by 2030, probably 30% of many correctional systems are anticipated to be 55 years of age or older. So that's quite a significant change and puts quite a strain on the infrastructure, current systems. Next slide, please. This is just a snapshot picture at the Oregon State Penitentiary. This is a reality for us and many of the AICs is the wheelchairs actually don't fit in many of the cells that we have in our older facilities. And so this is just a really easy visual to reinforce that. So the men shuffle into their bunks. Sometimes they have assistants there to help them, but not all of our facilities are ADA compliant. They weren't built with the ADA in mind when they were designed decades ago. And so that's one of the struggles we have, is trying to figure out how we can safely house people. And one of the reasons why we're looking to design new facilities, hopefully for the future. One of the other things that we found is that our staffing types, much like community levels of care in the prison system, we're going to have to recreate some of those community levels of care. And so you think about even our own family members and loved ones, many people end up in adult family homes, or they go to assisted nursing facilities. Maybe they go to dementia, Alzheimer's, memory care facilities. And we have all those same illnesses within the aging population in corrections. But of course, prisons were not designed as memory care facilities or assisted living facilities or adult family homes. So we do have to take a look at what we might be able to renovate and adapt to, but really a lot of that's probably most likely going to come out of newly designed facilities in the future. But just like the community needs, the correctional system has those very same needs. The compassionate release, Oregon does have a compassionate release statute. It is somewhat limited compared to some other states that I'm used to. So there's a few opportunities there, but really limited for us to be able to have geriatric AICs released to the community where they might be cared for. And then one of the concerns we have, of course, as our facilities are not able to take care of all the specialized needs of our geriatric population and even others that are not 55 and over, transporting them off-site to non-secure facilities in the community is always a risk for us. And so that's one of the things we're mindful of. We'd like to be able to do more care on site. We'd like to be able to do more telehealth through technology. So we are always looking at that balance of what may we be able to do on site versus what do we have to take off site to specialized care in the community. But of course, these facilities were not designed decades ago for telehealth or really specialized care. And then in current state of budget reductions, it just makes it more difficult to think about renovations and doing some things that might otherwise be seen as creative solutions just with reduced resources. And if we do reduce beds in any way, that just makes it a tighter system. Many of our geriatric population need lower bunks, or they need to remain on the lower floors of the facilities, and there's only so many beds that we can do there. So we do try to have to keep balance, and we have to rotate people to different facilities sometimes just simply for the fact that they need a lower bunk or cannot do stairs. Next slide, please. A couple of the big three things we have to work on. We talked about the EHR rollout. We should have the electronic health record system rolled out. We should be wrapping that up in April of 26 and be at all facilities if everything works out as planned. There is a study, a feasibility study, I believe, for design of a new Oregon State Penitentiary, and the department does have some funding for that. And so that work is being considered. And then the staffing makeup change. One of the things that's I find interesting about the state classification system is I was told we don't have a classification for medical assistants or certified nursing assistants that we might find in the other, out in community healthcare settings, maybe even next door at the state hospital in Salem. So I'm pretty used to running systems where we've got a diverse mix of different classifications we can use to help match up with the care needs of the population. And not having these staffing classifications does make it a little more difficult for sure. It forces us to use registered nurses where we could probably otherwise use medical assistants and some others. So it's putting a strain on our staffing. And one of the things we'd like to do is as we consider changing some of the housing and some of the programs we have for our geriatric AICs, we'd like to be able to consider using a different staffing mix to make sure we got the right complement in there to provide the care that's needed. So I think we're talking to DAS about that and hoping we can make progress on that soon. Next slide, please. This is really the last slide. These are just a few articles around geriatrics and corrections that added as references and sources, just good background reading. The one in particular, the first one from the National Commission on Correctional Healthcare is a good one, and that is a accreditation system that Oregon DOC is accredited with, so it's one that we follow closely and pay attention to. And with that, that's the end of my presentation. I'll open up any questions from committee members.
Well, Director, let me say thank you. I really appreciate this update. Couple of questions. One is that I am a former penitentiary corrections officer, so I know a little bit about, especially when you got outside prisoner escort and stuff, that takes 2 or 3 other additional persons to make sure that you are secured one individual. I know it's a drain on resources. Question is, are you having an opportunity for some of the AICs that may have a medical background to function as like an aide, someone, blood pressures and things like that, something that someone of low level, without certifications, can attend to. Here's an example. In the United States Army right now, all combat forces, individuals, are trained. It used to be just to splint a fracture or a chest compression. Well, now they're being taught how to insert IVs and a whole lot of other things. These are life-saving methods that are out there. I don't know if there's something that's been considered or you thought about it, but I did want to put that out there. This is what I consider an emergency in terms of how we react, especially when we have the big one come through. How are we going to be able to move those persons out of the facilities that can't move or are immobile? So it's a big deal that you're undertaking right now, and I agree. The system was not set up for anything like this. It was only for punishment, but now we know that punishment alone does not solve the problem. We don't need to have people age out and die, especially those for nonviolent offenses. So I applaud you on the work that you're doing there. I think there's a lot more that we must do. It is going to be a strain or a continuous strain on the corrections institution, having a place where it's specific for these individuals is a good thing. I don't know if the money is there. So everything seems to wrap right around to, do you have the money or show me the money? So, but I do appreciate that. Questions from the committee? Seeing none, thank you so much again, and I appreciate it. We'll look for a follow-up at a later date.
Thank you very much.
Closing second hearing, opening informational hearing on Legislative Revenue Office